So students, now in this video we are going to discuss 180 MCQs which are combined and which are from various topics of pharmacology. A patient was given intravenous botulinum toxin and the patient died. So what is the mechanism of botulinum toxic overdose? The options are: inhibits the release of acetylcholine, inhibits the reuptake of norepinephrine, blockade of postsynaptic nicotinic cholinergic receptors, inhibit the entry of acetylcholine in vesicles. So now inhibit the reuptake of norepinephrine, so that is a different. Botulinum does not act on norepinephrine. Blockade of postsynaptic nicotinic cholinergic receptors, so this action is not done by botulinum. This is done by basically the antagonist of nicotinic receptors. Inhibit the entry of acetylcholine in the vesicles, so this is done by vesamicol, right? And now inhibit the release of acetylcholine. This action is performed by botulinum. So botulinum toxin is basically used in treatment of spasms and wrinkles of the face, and it is also very popularly now known as Botox. So this is having an anticholinergic action. There's another substance that is called as hemicolinium, and hemicolinium is basically, the action is that it inhibits the uptake of choline by the neurons. So this is also, these three substances you need to remember here: botulinum, vesamicol and hemicolinium. These are the three important substances which you should remember when you are studying about the botulinum toxin. So I'll mark them: hemicolinium, vesamicol and botulinum toxin. Coming to the next question. Drug of choice in paracetamol overdose. Now paracetamol overdose means paracetamol की हो गई यहाँ पे poisoning, and paracetamol is metabolized by glutathione conjugation. Glutathione conjugation होता है. Now in small children, when the paracetamol is given in a very high dose, then it results in what? Toxicity. Alternate pathway में चला जाता है इसका metabolism, because there is not enough of glutathione, and that results in production of the metabolite which is N-acetyl benzoquinone imine. This is the toxic metabolite, right? And this toxic metabolite then causes damage to the liver and fever also. So this toxicity, to reduce this, we use antidote which is called as acetylcysteine, right? So here the correct answer is N-acetylcysteine. Dopamine is not used. Hydralazine is an antihypertensive. Furosemide is a loop diuretic. A young female presented with left-sided severe throbbing headache associated with nausea, vomiting, photophobia and phonophobia. Which of the following drug can provide immediate relief to this patient? So this is a case of acute migraine, right? Now in acute migraine, it is basically a headache with classical symptoms. So here, out of these drugs, propranolol, sumatriptan, topiramate and flunarizine. So acute attack mein we use sumatriptan, okay? Sumatriptan is used. Propranolol, topiramate and flunarizine is used in chronic. So here the answer will be sumatriptan. Next question. A patient on digoxin therapy accidentally consumed some tablets of digoxin, 0.25 milligram. 2 hours later, he presented to the emergency with heart rate of 54 and ECG evidence of 3rd-degree AV block. What is the immediate management of this patient? So this patient, which is on digoxin therapy, now he has developed digoxin. So this is a case of where there is digoxin toxicity. So here now digoxin immune, fab, lignocaine, phenytoin and DC cardioversion. So this is a case of digoxin toxicity, symptoms of bradycardia, arrhythmias. So here we have this digibind, or what we call as antibodies, digoxin immune antibody, which can be used in the poisoning. It is a very, very specific antidote for digoxin toxicity, so you can use this. So the answer out of all these is this. The next question. An 82-year-old patient presents with acute episodes of breathlessness. Chest X-ray shows pulmonary edema. History reveals that the patient has uncontrolled hypertension and is not taking the medication regularly. Which should be the management of this patient? Right? Now the patient is having breathlessness, pulmonary edema, uncontrolled hypertension. So in this, what should be the management? The options are IV nitroglycerin, salbutamol nebulization, intravenous salbutamol and intravenous antibiotics plus oxygen. Now here you have to understand that this patient is having pulmonary edema. Now pulmonary edema patient, the patient should be placed in a sitting position. Oxygen is delivered, right, to mask to obtain the arterial PO2 more than 60. Now here morphine, the first drug of choice that we will give is morphine. It is helpful in less severe decompensation also. So morphine is one drug which is given. It increases the venous capacitance also, so lowers the left atrial pressure and relieves the anxiety. But morphine can lead to carbon dioxide retention also because of respiratory depression. So should be avoided in patients with opioid-induced respiratory or pulmonary edema. Intravenous diuretic therapy. Now diuretic like IV diuretics like furosemide, etc. or bumetanide. Now the patient is usually indicated even if the patient has not exhibited fluid retention. So these agents also produce, they venodilatation भी produce करते हैं and diuresis भी करते हैं. Then coming to this nitroglycerin. So nitrate therapy accelerates the clinical improvement and it reduces both blood pressure and it also reduces the left ventricular filling pressure. So sublingual nitroglycerin or IV nitrate, they will reduce the dyspnea very immediately, right, prior to the onset of diuresis. So intravenous nitroglycerin out of all these options looks the most correct answer. There's another drug which is called as Neseritide. So Neseritide, which I am sure you all know that it is a recombinant form of human B type of natriuretic peptide. So this is also a very potent vasodilator, and it also reduces ventricular filling pressure, improves cardiac output. So these are the various drugs which will be used in the case of pulmonary edema. Coming to the next question. Which of the following hypolipidemic drug acts by inhibition of PCSK9? Now PCSK9, this is a new type of question. अगर नहीं भी आता है तो आप दूसरी दवाइयां देखो पहले. एटोर्वास्टैटिन स्टैटिन से, एज़ेटिमाइब नहीं, कोलेस्ट्रॉल एब्जॉर्प्शन इनहिबिटर है, लोमिटापाइड एंड एवोल्यूक्यूमैब, इन दोनों में आपको हो सकता है कंफ्यूजन हो. सो बट यहाँ पे आप समझो इसको, PCSK9, इट इज फुल फॉर्म इज प्रो प्रोटीन कन्वर्टेज सब्टिलाइसिन कैक्सिन टाइप 9. ये है PCSK. इट इज अ प्रोटीन, इट बाइंड्स टू LDL receptors, right, and transports them to lysosomes where they are then degraded. So inhibitors will prevent the destruction of LDLR and that will reduce the LDL cholesterol. Now इसमें जो drugs होती हैं उसका नाम है Electrolyte and Evolocumab. These are approved for, what is the approval? Familial hypercholesterolemia. That is what they are approved for, familial hypercholesterolemia, in adjunct to statin therapy. So here evolocumab, ऐसे याद रखो, PCSK9 cumab नाम से उसकी drugs होंगी. So this is the correct answer for this. Next question. A patient presents with pituitary tumor that overproduces growth hormone. Okay, now surgical removal is incomplete. What is the first line treatment? That means a patient is having a tumor and that is producing increased growth hormone secretion is there. Usually pituitary adenomas, and what will they produce? They will produce acromegaly. ठीक है, तो इस केस में now what is the drug treatment? Leuprolide, octreotide, neferalin, goserelin. Now in this acromegalic patient with incomplete remission after surgery, what is the therapy? Now usually we give one drug that is cabergoline, which is a dopamine agonist, and it is a dopamine agonist, and it also successfully treats the tumors for both PRL as well as, that is prolactin, as well as growth hormone. Can be also effective for patients with the normal serum prolactin. Cabergoline is given as monotherapy for patients, and it is safe during pregnancy. So it can be given during pregnancy also. Now another drug that is octreotide. So octreotide is another drug, and octreotide LAR and octreotide plain and lanreotide. These are the long acting somatostatin analogs, and these drugs are given by monthly subcute injection. Somatostatin analogs होते हैं ये, and monthly subcute injection देते हैं. ठीक है, so these are the two drugs. So here out of all the options that we have, we will take octreotide. There's another drug that is raloxifene. This raloxifene is we know it is a SERM, and this is used in persistent acromegaly, right? And then another drug that we have is pegvisomant. Pegvisomant is a growth hormone receptor antagonist, and it is given to patients who are resistant to all other treatments, right, along with diabetes mellitus. So the right answer here is octreotide. Next question is, a 40-year-old male presents with protrusion of chin, excessive sweating, impaired glucose tolerance, and enlargement of hands and feet. Now, which of the following drugs is a growth hormone receptor antagonist used to treat this condition? So this again is a case where there is acromegaly, and they are asking specifically growth hormone receptor antagonist. Now octreotide is a somatostatin analog, cabergoline is D2. I'll write here somatostatin analog. It is a D2 receptor agonist. Olzigipant is a CGRP receptor antagonist. So pegvisomant is a growth hormone receptor antagonist, and so pegvisomant is used in this treatment. This olzigipant is a CGRP antagonist used in the treatment of migraine, right? Next, a 40-year-old diabetic female presented to emergency with abdominal pain, vomiting, recent onset of confusion. On examination, she had irregular breathing and dehydration. Her blood sugar is 539. So diabetic female hai, pain, vomiting and confusion, irregular breathing, dehydration. Blood sugar is 539, presence of ketone bodies in the urine. Blood pressure is very low. What is the next best step in the management? So this is a case of diabetic ketoacidosis. Now diabetic ketoacidosis mein sabse pehle we start with IV fluids, and then we start with regular insulin. Regular insulin is the only insulin which can be given by IV route. So here we have to start regular insulin, IV fluid with regular insulin. So this is the correct answer. Next question. A female presents with galactorrhea. Urine pregnancy test negative. MRI reveals a large pituitary tumor. So this is a case again of pituitary adenoma. Patient refused to undergo surgery. Which of the following is the best drug? Now, out of the given options, octreotide, bromocriptine, promethazine, clozapine. For prolactinomas, which are basically secreting a lot of prolactin, what is the drug that we need to give? We need to give a drug which will reduce the dopamine. Now, it is out of the given option. Octreotide is a somatostatin analog, more suitable for growth hormone. So this is that. Promethazine and clozapine, these are basically antipsychotics, and they are used in when there is an excess of dopamine. So now the best option that we have here is bromocriptine. Bromocriptine is a D2 receptor agonist, right? And it is given to the patients having prolactinoma. Another drug that is very commonly used is cabergoline, and it has got a half-life of more than 60 hours. So just needs twice weekly dosing. So the dosing is also, schedule is good and more compliant. This is better tolerated also, and it is more effective also. Better tolerated and more effective. Right, so the right answer here is bromocriptine. Next, a patient with opioid poisoning presents. So patient with opioid poisoning presents with severe respiratory depression. What is the most effective drug for the treatment of this? Opioid poisoning hai fomepizole, naltrexone, flumazenil, naloxone. So here we are talking about the antidotes. So what is the antidote to opium? Or antidote to opioid is naloxone. And that is the answer. It is the drug of choice for acute opioid treatment. Naltrexone is used for maintenance in opioid poisoning, right? Due to its long duration of action. Fomepizole is the antidote for methanol and ethylene glycol poisoning, and flumazenil is used in benzodiazepine toxicity. So these are the four options, out of which the drug which we are going to give is naloxone. A patient on antidepressant therapy presents with elevated body temperature, dilated pupil, palpitations, and low blood pressure. ECG shows tachycardia, broad QRS complex, and right axis deviation. Now, which intervention must be done immediately? So here a patient is on antidepressant therapy and with all these symptoms. So these symptoms indicate that there is a TCA poisoning, that is tricyclic antidepressant poisoning. Now tricyclic antidepressant poisoning presents with cardiac arrhythmias, hypotension, and anticholinergic signs. So there are anticholinergic signs like flushing, dilated pupil, intestinal ileus and all. CNS symptoms like delirium, etc., hallucinations, they also occur. Now treatment the first treatment in TCA poisoning is intravenous sodium bicarbonate. This is wait and watch to nahi, intravenous esmolol DC cardioversion no. So here intravenous sodium bicarbonate is the single most effective intervention in the management of the cardiac toxicity. This bicarbonate can reverse the QRS, prolongation, and ventricular arrhythmias, and this is the drug of choice, the treatment of choice in sudden onset ventricular tachycardia or ventricular fibrillation. Then another drug which is used is lignocaine. Lignocaine is the drug of choice for TCA-induced arrhythmias, right? Ventricular dysrhythmia. However, care should be taken that there should not be any seizures. Seizures nahi aane chahiye patient ko. IV fluids, hypertension ke liye IV fluids de sakte hain. We can give dopamine. Then diazepam can be given in the management of seizures. And physostigmine is given in TCA poisoning because to reduce the cholinergic tone. So जो anticholinergic side effects हैं वो reduce हो जाते हैं. So physostigmine used only in patients where there is coma or there is convulsions, right? Next question, a patient presents with tremors, rigidity, and bradykinesia. Now, which drug is used for the treatment of this patient? So now this patient is having, you can say that it points to the diagnosis of Parkinsonism. Bradykinesia, rigidity, and tremors. Now, out of the given options, selagelene, donepezil, fluoxetine, haloperidol. Haloperidol is an antipsychotic and it is used in the treatment of psychosis. Fluoxetine is an antidepressant and so it is used in, it is an SSRI and so used in depression, anxiety. Donepezil is a cholinesterase inhibitor and is basically used in Alzheimer's, right? Selagelene is a selective MAO-B inhibitor and so this is the drug which is used in the treatment of Parkinsonism, right? Next question, a child born by normal vaginal delivery developed repeated attacks of flexion of neck over the trunk and jerk in the hand. EG shows presence of hips arrhythmia. Now, antiepileptic drug of choice for this patient. So, the patient is having hips arrhythmia and this is also basically infantile spasms, right? So, infantile spasm में phenobarbital, phenytoin, ACTH or levetiracetam. In तीनों में, चारों में से ACTH is the drug of choice. It is treated and this syndrome, it starts between 2 months to 12 months. Consists of, there is a triad of infantile spasm that occur in clusters. A typical EEG picture and a developmental regression. So, EEG will be there, spasms will be there and developmental regression will be there. So in this case, ACTH is the drug of choice. A 11-year-old boy presents to the emergency with vomiting. Parents give history of consuming 10 to 15 tablets of ferrous sulfate a day before. What is the antidote of iron for treatment of this patient? Now options given are dimercaprol, desferrioxamine, D-penicillamine and activated charcoal. So this clearly is a case of iron poisoning. And so now what is the iron poisoning antidote? So antidote used in iron poisoning is desferrioxamine. It is basically acute iron poisoning है. तो acute iron poisoning में हम desferrioxamine यूज़ करते हैं. अगर chronic iron overload होता है तो वहाँ पे हम यूज़ करते हैं deferriprone. Right, so this is the choice of antidote for the iron therapy. Dimercaprol is not used in iron poisoning because it causes a complex with iron and that is toxic. So that is why we don't use dimercaprol. Next, a patient with the thrombosis, a deep vein thrombosis patient started on an anticoagulant therapy. Okay, now next day the patient presents with the features shown in the diagram below. What is the likely drug implicated? Now this is a very specific case of dermal vascular necrosis. What are the options which are given to us? The options are heparin, rivaroxaban and warfarin and dabigatran. Now this dermal necrosis syndrome or purple toe syndrome is an early adverse effect of warfarin. Early adverse effect. It occurs within a few days of starting the warfarin therapy, and it occurs because warfarin actually inhibits the activation of the clotting factor, inhibits the activation of clotting factors, and which clotting factors are affected? 2, 7, 9 and 10, as well as anti-clotting factors, that is protein C and S, right? Now patients who are having a genetic deficiency of protein C, it may result in hypercoagulable state and result in dermal. So patients having a genetic deficiency of protein C are the ones which show this kind of adverse effect. Next, a patient with COPD is given intravenous aminophylline therapy following which he developed diuresis. So given IV aminophylline therapy following which he developed diuresis, right? Now this is due to effect on which receptor? So theophylline has got two actions. First of all, it causes the inhibition of phosphodiesterase 4 enzyme, and second, it inhibits the adenosine receptors. Okay. So now adverse effects due to phosphodiesterase inhibition will be GI side effects and cardiac toxicities, that is arrhythmia. And adenosine receptor antagonism से arrhythmias होंगे, diuresis होगा and epilepsy. So that means it will result in arrhythmias. Diuresis मतलब kidney पे effect है and epilepsy मतलब CNS. ठीक है, तो यहाँ पे this effect diuresis is because of which receptor? It is because of adenosine receptor action. ठीक है. A patient with ovarian cancer is on cisplatin therapy, right? She has developed several episodes of vomiting. After giving an antiemetic, the patient developed dystonia. So the antiemetic drug most likely to be responsible for these features. Now dystonia से फिर हम क्या समझते हैं? Dystonia मतलब कोई ऐसी दवाई जो कि D2 antagonism करा उसने, है ना? तो कौन सी दवाई है यहाँ पे? Metoclopramide, Meclizine, ondansetron and scopolamine. Now out of all these drugs, the drug which caused dystonia is metoclopramide because it is having an action on D2 receptor and it is D2 receptor antagonist. So now what will be the drug of choice for treatment of dystonia? So treatment of dystonia, you will do anticholinergic drug like benzhexol, which is trihexyphenidyl, promethazine. This can also be used as an antidote. The next question, a pregnant female with UTI took antimicrobials for the same. The baby developed tendon rupture and arthropathy. What is the likely mechanism of action of the antimicrobial consumed by the pregnant female? So a drug, an antibiotic that causes tendon rupture and arthropathy is usually caused by fluoroquinolones, and fluoroquinolones is an inhibitor of DNA gyrase enzyme. So this now, let's see the options: folic acid synthesis inhibitor, mycolic acid synthesis inhibitor, DNA gyrase inhibitor and DNA inhibitor. So this is the correct answer here. Next. A 48-year-old patient presented to OPD with tingling and numbness of fingers. The patient is chronic alcoholic and recently started on AKT. Okay, so what should be the treatment? Now patient has started with ATT, that is antitubercular drug, and has developed tingling and numbness. So this is a sign of neurological manifestations hai, and that is peripheral neuropathy or neuritis. So this is usually the toxic effect of INH. The options given here are B3, B6, B1, B12. Now this is because INH interferes in the utilization of the vitamin, that is pyridoxine, right, and it causes increased excretion. So deficiency of pyridoxine is causing this. So pyridoxine is vitamin B6, so the correct answer here is vitamin B6. So we need to replenish pyridoxine to treat the peripheral neuropathy. Next, in MDR tuberculosis, which of the following drug combinations to show resistance? Now drug resistant tuberculosis. Okay, what are the options? Rifampicin, fluoroquinolones, isoniazid rifampicin, isoniazid parazinamide and rifampicin kanamycin. Now let's see the resistance pattern. So monodrug resistance is usually either isoniazid or parazinamide or ethambutol. If it is a polydrug resistance, then it is usually 2 or more than 2 drugs amongst H, Z or E. Now rifampicin resistance is basically resistance to rifampicin. Multi-drug resistance, what is MDR? MDR is when there is resistance to isoniazid and rifampicin. And XDR, what is XDR? XDR or extensive drug resistance is resistance to isoniazid, rifampicin, one of the fluoroquinolones and minimum one injectable drug. So this is XDR. So please remember these classification. So now here in MDR tuberculosis, the drug combination which shows resistance is isoniazid and rifampicin. So that is the correct answer. The next question. A patient presents with hyperkalemia. Which of the following drugs can cause intracellular movement of and thus decrease the extracellular potassium levels? So now a drug which will basically drive potassium inside. So options given are atropine, lactic acid, epinephrine and glucagon. Now out of all these drugs, the 2 drugs that have the capacity to drive potassium inside the cell is insulin and beta-2 agonist. Okay? So beta-2 agonist हमारे पास होते हैं salbutamol and epinephrine. So these are the drugs which cause which basically cause increased intracellular movement of potassium, intracellular movement of potassium. So this action is utilized in the treatment of hyperkalemia, right? So the right answer here is epinephrine. Next, which of the following drugs have least adverse effect on pleura? Wow. So drugs having least adverse effect on pleura: bromocriptine, metformin, nitrofurantoin and methysergide. Now methysergide, we know it is associated with pulmonary fibrosis, right? Nitrofurantoin can result in pleural effusion. The 2 drugs which we remain with are bromocriptine and metformin. Bromocriptine also causes pleural effusion or fibrosis, pleural fibrosis on long-term use. So the drug only option that we have is, because they have asked least adverse effect. So the correct answer here is metformin, right? Next, as an Indian medical intern, which of the following is the correct format of prescribing alprazolam? Now options are tablet alprazolam 0.5 mg once a day before bedtime for 7 days. Second option, tablet alprazolam 0.5 mg HS for 7 days. Tablet alprazolam 500 microgram 1 tablet OD for 7 days. And tablet alprazolam 0.5 mg tablet HS daily. Now what are they trying to ask in this question? They're trying to ask Indian medical intern. So an intern is one, as a fresh medical graduate, they want to test your ability to write a prescription correctly. So this is the question here. Prescription आपका सही है या नहीं है? So that is what they want to understand. So सबसे पहले जैसे इसमें abbreviations आ रहे हैं. So a prescription should not have abbreviations. They should be avoided. Now in both this B and D, there we have abbreviations. Then secondly, this also has OD. So all the 3 have got abbreviations. So this tablet alprazolam 0.5 mg once a day before bedtime for 7 days. So this becomes the correct answer here because no abbreviations are there in that option. So these type of questions, remember, they're trying to test the ability to write a correct prescription. The next question, rate of administration of a drug is equal to the rate of elimination. How will you calculate the dosing rate of the drug to maintain a steady state plasma concentration? So when rate of administration is equal to rate of elimination, so this indicates that it is a first order kinetic reaction. Okay. So what will be the dosing rate of the drug to maintain the steady state concentration? So at steady state, when the rate of administration is equal to rate of elimination, to maintain this, the dose given has to be the maintenance dose, right? So यहाँ पे आपने पढ़ा होगा, we have 2 types of doses, loading dose and maintenance dose. So यहाँ पे आपको बस trick है ये निकालना कि वो कौन सी dose पूछना चाहते हैं. They want to ask you the maintenance dose because they are saying that rate of elimination is equal to rate of administration. So to maintain the steady state plasma concentration, you just need to give a maintenance dose. Now maintenance dose, I'll tell you loading dose, it depends upon the volume of distribution, while maintenance dose depends upon the clearance. So the correct answer here is dosing rate is VD and VD. ये दोनों तो कट हो गए. अब अच्छा dosing rate is equal to CL into CPSS and dosing rate is equal to CL upon CPSS. So the correct formula is this. Dosing rate is equal to CL into CPSS, right? So this is the answer. If they had asked loading dose, then it would have been VD into CPSS, right? So maintenance dose is CL into CPSS. Next, a patient with bronchial asthma presents with raised intraocular pressure. Now treatment of open angle glaucoma in this patient. So this is a patient with bronchial asthma and a raised intraocular pressure. So now here you cannot give a drug which can result in precipitation of bronchial asthma, right? First of all, so you have to take care that bronchial asthma bhi uska theek rahe. So drug of choice, now primary open angle glaucoma, we have PGF2 alpha analogs, right? Options that are given are latanoprost, alprostadil, gemprost and carboprost. Now latanoprost is PGF2 alpha, right? Alprostadil is PGE1 and it is used to keep the patent ductus arteriosus and also in erectile dysfunction. The next gemprost. Gemprost is PGE1 analog used in cervical ripening. Okay. And carboprost is PGF2 F2 alpha used in postpartum hemorrhage. So these are the 4 drugs and 4 uses, and so the correct answer here is latanoprost. A patient presented, next question. A patient presented with suspected cocaine overdose. Which of the following features is not seen? Now cocaine is basically a drug that will, what is the mechanism of cocaine? पहले तो समझ लेते हैं. Cocaine will inhibit the reuptake of adrenaline. ठीक है, noradrenaline. So reduce the reuptake of noradrenaline. So it will increase the amount of noradrenaline in the synaptic cleft. So there will be increased sympathetic effects by cocaine. ठीक है. So what is the feature not seen? Sympathetic effect. अब option क्या है? Bradycardia, agitation, amine, hyperthermia. So it will result in abnormally fast rhythm. Cocaine will result in fast rhythm. So bradycardia is the right answer. Agitation it will cause hyperthermia because there is stimulation, increased muscular activity, and psychological symptoms. Okay, myocardial infarction can be precipitated, acute respiratory failure, stroke, sudden hemorrhage. So many things can be precipitated by cocaine poisoning. So the correct option, because they are asking not seen, the correct option is bradycardia, right? The next question is, a child presents to the hospital with agitation, photophobia and retention of urine. Okay, agitation hai, photophobia and retention of urine. History reveals that he has eaten a wild fruit given by his friend. Which of the following substances is likely cause of poisoning and antidote respectively? So a patient, the history indicates that a patient has eaten a wild fruit. So most probably it is either dhatura or yellow oleander. And which substance is likely to cause the poisoning and antidote? Now symptoms of agitation, photophobia and retention of urine, they are indicative of anticholinergic poisoning, that is atropine poisoning. Okay, retention of urine, photophobia because of mydriasis. Now dhatura is an important source of atropine, so it is likely to be the causative plant. Now what is the antidote? They are also asking antidote. Is pralidoxim the antidote or physostigmine the antidote? So anticholinergic poisoning mein physostigmine is the drug of choice. Physostigmine is anticholinesterase inhibitor, acetylcholinesterase inhibitor, anticholinesterase. So this is used in the treatment of poisoning by atropine. So the right answer here is dhatura and physostigmine. The next question is, a 45-year-old patient is being treated with low-dose aspirin since 6 months and presented with rectal bleeding. Okay, now inhibition of which substance is likely to be responsible? It's a very, very simple question. Aspirin is an irreversible, please remember this word, irreversible inhibitor of COX enzyme. So it is a non-selective irreversible inhibitor of COX enzyme. And then due to inhibition of COX enzyme, what it does is, it increases the prostacyclin PGI2 and it reduces the thromboxane A2. And reduction in thromboxane A2, this is actually pro-aggregatory, right? So reduction, and this is anti-aggregatory. So because of their combined action, we get reduction in the aggregation, right? Because thromboxane A2 is inhibited. So here aspirin will reduce the thromboxane A2 activity. So this substance is responsible for the bleeding of the patient. Next question, a 34-week pregnant female with polyhydramnios presents with labor pain. She was treated with indomethacin earlier. Which of the following can be the likely outcome in the baby if the delivery occurs? Now, polyhydramnios, 34 weeks pregnant hai, labor pain ho gaya, isko indomethacin diya gaya hai. Now, indomethacin is an NSAID. Okay, now what can be the likely outcome? Indomethacin dene ke baad, patent ductus arteriosus, premature closure of patent ductus arteriosus, patent ductus venosus, premature closure of patent ductus venosus. Now, we all know that NSAIDs, they result in premature closure of patent ductus arteriosus. So, here it can, indomethacin will decrease the prostaglandin synthesis and will cause a premature closure of patent ductus arteriosus, right? So that is the right answer here. Next question, a 60-year-old female with renal disease admitted for pyelolithotomy. Post-operative analgesic of choice in this patient will be. Now, patient is already a case of renal disease. Matlab, there is renal toxicity. So इस case में analgesic, diclofenac, indomethacin, naproxen and acetaminophen. In some, most of the NSAIDs, they can result in renal toxicity. So here we will use acetaminophen, that is paracetamol, which is having the least analgesic nephropathy, right? Next question. A 45-year-old patient presented with the symptoms shown in the image below. Patient is a known hypertensive and was taking some antihypertensive drug. Symptoms क्या हैं इसके यहाँ पे? There is swelling of the lips. So this swelling of the lips is indicative or is called as angioedema. So which drug is likely to cause this condition? Now out of the given options, lisinopril, clonidine, nifedipine and timolol. So out of these, all the options, the drug which causes angioedema is lisinopril. Clonidine, nifedipine, timolol, they do not cause. Lisinopril, which is an ACE inhibitor, it has a tendency to cause these side effects. So the correct answer is lisinopril. Next question, tocilizumab is an immunosuppressive drug which is used for rheumatoid arthritis. It is a monoclonal antibody against interleukin 6, 12, 2 and 3. So tocilizumab is immunosuppressive drug, monoclonal antibody against interleukin 6. So right answer is this, and it is used in rheumatoid arthritis. It was used in COVID-19 also. Cytokine release syndrome में भी इसको use करते हैं. Cytokine release syndrome. This drug is used there also. A patient on digoxin therapy had a level of 1 nanogram per ml. He was receiving other drugs and presented 2 months later with flattening of the T wave in ECG. Now the plasma level of digoxin is 3.8 nanogram per ml. So which drug is responsible? So here basically there is a toxicity of digoxin. Now which of the drug is responsible? Now see, the options that they have given are trimethoprim, which is a potassium sparing diuretic, and atenolol, which is a beta blocker, and clarithromycin, which is an antibiotic, and KCl. Now these drugs, trimethoprim, atenolol, clarithromycin, these drugs are likely to cause hyperkalemia. Trimethoprim hyperkalemia karega, atenolol, KCl hyperkalemia karega. Here, what is clarithromycin doing? Clarithromycin is a basically drug that causes digoxin toxicity by inhibiting the renal excretion of digoxin. So by inhibiting the renal excretion of digoxin, clarithromycin resulted in the toxicity. So the correct answer here is clarithromycin. A hypertensive patient presented with chronic renal insufficiency and pedal edema. On investigation, serum creatinine was found to be 1.9. Now, which of the following drugs should be used for the management of hypertension in this patient? Now, there's a very question which needs understanding. Renal के जो patients होते हैं, उसमें आप ACE inhibitors या फिर ARBs you can give, right? Now, they are avoided if the serum creatinine is very high, like more than 3.5. Then diuretics, like thiazides and they're the second line drugs, and they are found to be ineffective in severe renal disease. When GFR is less than 30 or creatinine is more than 2.5, then again diuretics are not effective, right? Chlorthalidone preferred because of its long duration of action. Metolazone is also effective in severe renal failure, and torsemide is another loop diuretic, can also be used in severe renal disease. Then we have CCBs, calcium channel blockers. They can be used as alternative second line agent in renal disease. Renin inhibitor like aliskiren. Aliskiren can be used in treatment of hypertension but avoided in renal disease, right? Then we have alpha blockers. So alpha blockers are also preferred when there is urinary obstruction. Beta blockers not indicated in as a first line drug and not indicated in renal disease. Now here the options which we have is alpha blocker, aliskiren, chlorthalidone and metoprolol. So out of all the options that we have, chlorthalidone is used in the management of patient with a high creatinine. They can be used till 2.5, so they are effective. If we had ACE inhibitor or ARB as an option, then we could have taken that as the first answer. Next question, a 26-year-old female comes to the hospital for preconceptional counseling. Patient is a known hypertensive compliant to drug therapy. Which of the following drugs will you advise to stop? Right, so the drug, now that means safe in pregnancy. Which hypertensive is safe in pregnancy? It is methyldopa, labetalol, lisinopril or nifedipine. Labetalol is a drug. ACE inhibitors, see ACE inhibitors, they are completely contraindicated. तो contraindicated होते हैं. Methyldopa is given, this is better. Nifedipine, CCBs are not, and beta blockers. So safe in pregnancy अगर हम देखें तो here then the answer will be, which drug will you advise to stop? Okay. The drug which you will advise to stop is lisinopril. Lisinopril is the drug which you will not give. This is the correct answer here. Methyldopa can be given. Labetalol is beta blockers are safe. Nifedipine, DHP like amlodipine वगैरह, amlodipine is safe in pregnancy. Clonidine is safe in pregnancy. Hydralazine is safe. Then alpha blockers like prazosin, they are safe. But lisinopril, that is ACE inhibitors, not safe, is lisinopril or ACE inhibitors, right? Patient with a history of mitral stenosis, stroke, presents with irregular heartbeat, right? There is no clot in the left atrium on TE. Patient is already on ACE inhibitors and statins. Now, which of the following drugs should be added for stroke prevention? Options are warfarin, dabigatran, aspirin with clopidogrel and aspirin. Now, medication to reduce the risk of stroke patient with history of transient ischemic attack or ischemic stroke, especially with the patient having a history of mitral stenosis. Here, the answer is warfarin. Now, why warfarin? Now see, directly acting anticoagulants like dabigatran, etc., aprixaban, rivaroxaban, edoxaban, they are preferred over warfarin in non-valvular atrial fibrillation. Okay, if it is non-valvular atrial fibrillation, then directly acting anticoagulants are preferred. If the patient has renal disease, then you give warfarin or aprixaban. Okay. Then valvular heart disease and atrial fibrillation. If there is a valvular heart disease and moderate to severe valvular heart disease, then you have to give warfarin there, right? Now, that is valvular plus atrial fibrillation. Now, if the patient is valvular disease plus normal sinus rhythm, then warfarin. And this is for mechanical mitral valve or aortic valve, and for all other non-rheumatic disease है तो फिर aspirin 75 milligram is indicated, right? So this is the answer for this question. Remember the concepts here. Next question, a 50-year-old male presents to the hospital with complaint of chest pain. Angiogram revealed left circumflex artery occlusion. So angiogram mein there is an occlusion. Stenting is done and patient is started on aspirin 75 milligram atorvastatin 20 and metoprolol 50. Now which statement is correct regarding further management of this patient? So patient is having a chest pain and angina and there's an artery obstruction, so stenting is done and patient is given aspirin, atorvastatin and metoprolol. Now for the management, what drug will you use? Now here the options given are add a P2Y12 receptor blocker, increase the dose of aspirin, increase dose of metoprolol, add nifedipine. So what are we going to do in this case? Now in this case, increased dose of aspirin, no. Aspirin we are already giving 75 milligram. So we have to give low dose. Increased dose of metoprolol to 100. This is also not correct. Metoprolol has to be given in this dose only. Add nifedipine. CCB को add करने से कोई benefit नहीं है. Here we need to give the patient an anticoagulant. And this P2Y12 blocker, that is clopidogrel or prasugrel, this will be added to that patient. So that will reduce the chances of any clotting. So it is called as dual antiplatelet therapy. Okay, this is called as DAPT and this is recommended after attack, recommended to prevent restenosis, right, after stenting. So this is the drug therapy which is given to the patient. Next question, a 36-week pregnant female was taking warfarin for prosthetic heart valve and has an INR value of 3. So warfarin, they are taking an INR value 3 here. So what is the next step in the management? Now as we can see that the INR value is very high and so there is definitely a high dose of warfarin toxicity. So now, and secondly, she is a pregnant female. So now pregnancy mein warfarin INR value bhi zyada hai, prosthetic heart valve hai, so stop warfarin and start with heparin. So this warfarin, otherwise it will increase the risk of vitamin K deficiency and it will result in the hemorrhagic disease of the newborn. So warfarin has to be stopped at the term and heparin has to be started. So it should be replaced. A 60-year-old post-menopausal woman having a previous history of Colles fracture presents with backache. Which of the following statements about anti-osteoporosis drugs is false? So remember, what is false? So what is false ढूंढने के लिए हमको देखना पड़ेगा पहले what is correct. Calcium requirement is 1200 milligram per day. Right. Oral vitamin D should be given along with calcium supplement. Right. Bisphosphonate therapy should not be given for more than a year. Now, more than a year, they should be continued for 5 years and then depending upon the risk of fracture. Bisphosphonate holidays are planned for 3 to 5 years. Teriparatide therapy should be followed by bisphosphonate therapy. So, yes, teriparatide ke baad it should be followed by anti-resorptive therapy like bisphosphonates. So, the correct answer here is, which statement is false? Should not be given for more than a year. It can be given for around 5 years. Right. Now, let's see the drugs which are important for postmenopausal osteoporosis. What are the drugs? Bisphosphonates are given here. These are anti-resorptive and a drug of choice in postmenopausal osteoporosis. Teriparatide is a synthetic parathormone and it is also indicated in females with high risk of fracture, given for around 2 years, followed by anti-resorptive therapy. Then other drugs that we have is denosumab, and denosumab is basically a monoclonal antibody and it is also anti-resorptive and used in females with high risk of fracture. Then the other drug that we have is raloxifene. Raloxifene is given in postmenopausal osteoporosis, especially if they have a low risk thromboembolic episode and have a family history of breast cancer, right? Then ये हो गई. तो ये सारी drugs हैं हमारी जो कि osteoporosis में काम आती हैं. Next, an anesthetist injected bupivacaine in a patient for axillary nerve block. Later, the patient developed restlessness, agitation, CV, collapse. Next best step in the management. So, patient was given bupivacaine and developed axillary nerve block, restlessness, agitation, cardiovascular collapse हो गया. So, what is the next step in the management? Now, here it is basically a local anesthetic toxicity, right? So, management कैसे होता है इसमें? अगर seizures आ रहे हैं तो GABA agonist देना है, GABA agonist. Vasopressors can be given for cardiovascular toxicity. Then, total cardiovascular collapse is treated with CPR plus 20% lipid emulsion. So this is the therapy. So here dopamine, vasopressors दे सकते हैं. Dantrolene is basically used in malignant hyperthermia. Soda bicarb नहीं. So this is the right answer. Cardiac resuscitation plus intralipid. A patient was admitted for surgery and halothane is being planned to be used as an anesthetic agent. Okay, halothane now यहाँ पे use होगा. The patient is explained about the adverse effect of malignant hyperthermia. Which of the following drugs may also result in malignant hyperthermia? Now, which drug together with halothane? Succinylcholine, D-tuberculin, dantrolene, baclofen. Baclofen is a central relaxant. Dantrolene is actually used in the treatment. है ना? तो ये तो क्या करेगा? D-tuberculin और succinylcholine में से succinylcholine is the one. It is triggered. Succinylcholine triggers malignant hyperthermia, right? And succinylcholine. So, halothane and succinylcholine, they are the ones which cause malignant hyperthermia. A patient presents to the hospital with 3 bouts of vomiting and treated with antiemetic. Vomiting subsided, but after some time he developed abnormal movements. Which of the following drugs is used for the treatment of these motor symptoms? So that means the patient was given an antiemetic drug, that was metoclopramide, and because metoclopramide is actually a D2 receptor antagonist, D2 blocker करता है, so that is why it caused abnormal movements, which are basically acute muscular dystonia type of condition. Now acute muscular dystonia में we have to use treatment is anticholinergics. So anticholinergics हमको यहाँ देने हैं. So what is the anticholinergic? Benzoxol, cyproheptadine, L-dopa and hyoscine. So out of all these, we will be using benzoxol. This is the anticholinergic which is used in the treatment of acute muscular dystonia. Promethazine is also used if benzoxol is not available. Next, a patient having a history of paronychia on finger presents with the following features as shown in the image. The drug of choice for treatment of this patient. Now paronychia history hai and given figure suggest that there is lymphangitis. Okay. Now this is basically infection of lymphatics due to infection in the proximal area, that is paronychia. Now this is mostly caused by streptococci. So what will be the drug of choice here? What are the options? Coamoxiclav, Norflox, erythromycin and amikacin. So Norflox, erythromycin, amikacin and coamoxiclav, that is amoxicillin plus clavulanic acid is the drug of choice in this case. If MRSA hota hai, if MRSA is the suspected agent, then cotrimoxazole has to be given. Next question, a female taking OCPs acquired tuberculosis. After prescribing anti-tubercular, physician advised patient for alternative contraception. What is the probable reason? Always जब AKT की बात आती है और उसके फिर आपके interactions की बात आती है, तो आपका ध्यान सबसे पहले जाना चाहिए किस दवाई पे? रेड अलर्ट कहाँ पे हो जाना चाहिए? Rifampicin. Rifampicin is the culprit. ठीक है? Now let's see the answers. Rifampicin causes teratogenicity. Isoniazid is teratogenic. Rifampicin increases the metabolism of OCPs, and OCPs decrease the efficacy. So here the answer is this: Rifampicin increase the metabolism of OCPs. So because of this, then rifampicin is an enzyme inducer, right? So it will induce the metabolism of OCPs and it will cause failure of OCPs. Now failure of OCPs hote hi the patient can become pregnant. So that has to be ruled out. So that is why the doctor has suggested using another contraceptive. The next is metronidazole is used for the treatment of various anaerobic infections as well as bacterial vaginosis. Now patient is instructed to avoid taking which of the following substance after metronidazole to avoid possible adverse effect. Now metronidazole ke saath mein grapefruit juice, milk, alcohol or orange juice. Which is contraindicated? Alcohol, because metronidazole with alcohol can result in disulfiram-like reaction. So then this is something that everybody has to be aware of. So metronidazole, basically it inhibits enzyme aldehyde dehydrogenase, and because of inhibition of this enzyme, if a person consumes alcohol, then there will be development of toxic metabolites and then disulfiram-like reaction will happen. A patient of borderline leprosy received multi-drug therapy. Okay, multi-drug therapy le raha hai, he developed skin lesions. How should this patient be managed? Should we stop MDT and give thalidomide? Should we continue MDT and give thalidomide? Should we stop MDT and give steroids? Should we continue MDT and give steroids? Now in this type of case, the MDT has to be continued. This is basically a type 1 lepra reaction, right? And in such cases, the MDT has to be continued and treat them with steroids. So here the right answer is this. Next, a 20-year-old boy presents with slow-growing mass on the medial side of thigh. Investigations reveal that it is an osteosarcoma and patient is started on methotrexate. Mechanism of action of methotrexate as an anti-cancer drug. What is methotrexate mechanism? What is the action? Now methotrexate basically inhibits the dihydrofolate reductase enzyme. It inhibits dihydrofolate reductase. So this results in dihydrofolate का conversion into tetrahydrofolate. इसमें ये यहाँ पे inhibit हो जाता है by methotrexate. So because of this inhibition, then tetrahydrofolate is not available for metabolism and the body suffers. There are a lot of one carbon chain reactions which are suffering. So what is the correct answer? Inhibition of dihydrofolate reductase? Yes. So this is the correct answer. Okay. Next, topical application of 400 microgram per ml of mitomycin C is used. Now mitomycin C के two topical applications हैं, two topical uses हैं. First is subglottic stenosis and second is intravesical treatment of bladder carcinoma. Okay, so now here out of the given options we have subglottic stenosis, which is the correct answer. Now which of the following factors in PC versus time graph, that is plasma concentration versus time graph, is a measure of extent of drug absorption? Now see, remember, extent of drug absorption, okay, that is the measure of area under the curve. Half-life is the time in which 50% is reduced. Cmax is the maximum concentration and Tmax is the time to achieve maximum concentration. Okay, so area under the curve indicates extent of drug absorption. Tmax is actually the rate of drug absorption. Okay. Next, manufacturer of a drug company labels the drug contains 500 paracetamol, 500 milligram, but on quantitative analysis, it was found to have only 200. Now, what is this drug known as? So now the options are spurious drug, adulterant drug, unethical drug, and misbranded. Now, spurious drug is actually, इसको बोल सकते हैं हम धोखे वाली ड्रग. धोखा कैसे कि मतलब ऐसे डुप्लीकेसी कर रहे हैं, नाम कुछ ऐसा रख रहे हैं जिससे कि ऐसा लग रहा है कि ओके दिस इज दैट ड्रग बट इट इज नॉट एक्चुअली दैट. सो हियर इट इज स्प्यूरियस का मतलब ये होता है इट इज नॉट स्प्यूरियस, इट इज द सेम पैरासीटामोल. सेकंड है अडल्टरेटेड मीन्स कंसिस्ट ऑफ सम आइटम कंटेमिनेशन, राइट, समथिंग विच इज नॉट हेल्दी आइटम. अनएथिकल ड्रग मतलब अनएथिकल का मतलब क्या होता है? अनएथिकल मतलब वो ड्रग उस पेशेंट में नहीं देनी है, दैट इज अनएथिकल. एंड मिसब्रांडेड ड्रग विच हैव बेसिकली अ मिसब्रांडेड ड्रग इज समथिंग इफ इट इज कलर्ड, कोटेड, पाउडर्ड and polished and damage is concealed or not labeled in the prescribed manner, or the label contains anything accompanying the drug which is not right or which is a false claim. So here a false claim wala condition misbranded drug mein aati hai. So here 500 milligram ko 200 milligram dikhana is a false claim, so it comes as a misbranded drug. So the right answer here is misbranded. Now this is a very interesting question. Which of the following statement is correct regarding the given graph? So this is a graph given here, and as you can see this is the baseline 0 पे यहाँ पे एक drug है A, B, C and D. Okay, the A drug is having, it is what, receptor response, and this is I think the time. So A drug is going up like this, B drug उससे नीचे है, C drug थोड़ा नीचे है, and D drug is बिल्कुल नीचे. Now let's see what are the options. Drug A represents agonist, drug B represents inverse agonist, drug C represents agonist and drug D is inverse agonist, drug A is agonist and drug D is inverse agonist, drug B is partial agonist and drug C is inverse agonist. Now here I think the answer is very clear to you. The drug A is agonist. एक चीज हम पूरे कॉन्फिडेंस के साथ कह सकते हैं कि ये agonist है, because what, इसकी affinity है +1 and इसकी intrinsic activity है +1. This drug is inverse agonist, right? Inverse agonist है this drug, and D has got affinity +1 and intrinsic activity is -1 in the negative direction. This is a partial agonist. Now partial agonist में क्या होता है? That it has got affinity +1 and intrinsic activity is between 0 to 1. And this is an antagonist, as you can see that it has got affinity of +1 but its intrinsic activity is 0. So it is not having any action of its own. So this is the answer, and remember this concept also. The next type of stimulatory G protein in PIP2 phospholipase activation pathway. PIP2 that means कौन सा pathway बोल रहे हैं? PIP2 से निकलता है IP3 and DAG. So this is basically metabolized by GQ. GQ drugs they bind to this receptor and this activates the G protein, and activation by GS. GS usually कैसे करता है? Increases cyclic AMP, right? Increases the adenylyl cyclase which increases the cyclic AMP. GS and GI they both. GQ it acts by IP3 DAG pathway, and GO is nothing. I don't think I've ever heard about GO, so this is nothing, right? The next question is identify the type of inhibition from the given graph. Now given graph, see this is x-axis, y-axis, and here the slope change, y-intercept same, so this is inhibitor and this is no inhibitor. This is the interception between them, that is 1 upon Vmax. Okay, and so this basically is like a plot of dose upon velocity of the reaction. So now what is the type of inhibition that is seen here? Now the inhibition that we are seeing is, before that let's see what are the various types of inhibition, and this is known as Lineweaver-Burke plot. Okay, Lineweaver-Burke plot for enzyme inhibition. So competitive inhibition में क्या होता है? There is Km is increased and Vmax is unaffected. That means to achieve the same Vmax we need to increase the substrate concentration. Then uncompetitive inhibition में Km is reduced and Vmax is also reduced, right? And non-competitive inhibition में Km is unaffected and Vmax is reduced. That means आप कितना भी Km बढ़ाओगे Vmax कभी भी पूरा नहीं आ पाएगा जितना कि उसने आना था. So this type of graph, this is showing a competitive inhibition. Non-competitive inhibition में these two will not intercept here, and in uncompetitive inhibition they'll run parallel. A 20-year-old boy brought to the emergency room after consuming some unknown substance. The patient is sweating profusely, saliva drooling from the mouth and tears present. The boy has involuntary urination, diarrhea. Examination पे the heart rate is 58 beats. Blood pressure is 80/60. Which is the drug of choice for the treatment of this patient? So here it is a poisoning case. Okay, and the patient is having saliva drooling from the mouth and tears are present. The boy has involuntary urination and diarrhea. Examination में heart rate इतना है, blood pressure इतना है. So this looks like a case of OPC poisoning, organophosphorus poisoning. So symptoms are basically an extension of the acetylcholine symptoms. So there is pinpoint pupil. The patient has salivation, bronchoconstriction, sweating, urination, bradycardia, hypertension, coma. Blood pressure, heart rate may increase rarely. Now atropine is the antidote. So the options, out of the options that we have, atropine is the drug of choice here. Naloxone, N-acetylcysteine is used in paracetamol poisoning. Then naloxone is used in morphine poisoning, and physostigmine is actually used in atropine poisoning, right? Next, A patient with pre-existing liver disease consumed a drug and developed worsening of liver dysfunction. The metabolite of the drug responsible is N-acetyl para-aminobenzoquinone. The likely implicated drug in this case is paracetamol. We know that paracetamol is metabolized by glutathione conjugation, and glutathione khatam hone pe, then it results in formation of N-acetyl benzoquinoamine, that is a toxic metabolite, and treatment ke liye then we use N-acetyl cysteine. So this is the antidote which is used for the treatment of poisoning of paracetamol. Which of the following is not the primary treatment agent in rheumatoid arthritis? Okay, so the question is not the primary treatment agent. Methotrexate, sulfasalazine, hydroxychloroquine, azathioprine. Methotrexate is definitely the primary treatment. It is the first line DMARD, right? Then sulfasalazine is also used in patients. Hydroxychloroquine is also used. So the drug which is not the first line treatment is azathioprine. Azathioprine is an immunosuppressant, and initially, ekdam starting mein, it is not given. Not the first line drug in the treatment of rheumatoid arthritis. Identify the correct match regarding the drug and its adverse drug reaction. कौन सा correct है यहाँ पे? The question is which one is correct? Hydralazine, heart failure. Verapamil, constipation. Aliskiren, hypokalemia. Atenolol, hemolytic anemia. Now, hemolytic anemia is not caused by atenolol. It is caused by methyl dopa. So ये वाला option तो बिल्कुल definitely गलत है. Now, renin inhibitors they cause hyperkalemia. They do not cause hypokalemia. So ये option भी गलत है. Hydralazine is used for the treatment of heart failure. तो ये इसका adverse effect थोड़ी करेगा. Verapamil, they cause constipation as the side effect. So out of all the 4 options given, we have this as the correct answer. Next, which of the following anti-diabetic drugs is associated with increased risk of fractures in a female with osteoporosis? कौन सी anti-diabetic drug से increased risk of fractures होता है? Now the options given are canagliflozin. इसमें कुछ options में गलती हो गई है. इधर चलेगा इधर के इधर. Okay, sorry. So one is canagliflozin, one is rosiglitazone, and one is repaglinide. Okay, and here it is 72 hours and 120 hours. Okay, so antidiabetic drug causing osteoporosis: canagliflozin, rosiglitazone, voglibos, and repaglinide. Now, out of all these drugs, the thiazolidine ions like rosiglitazone, pioglitazone are associated with the increased risk of fractures. So the correct answer here is rosiglitazone. हाफ लाइफ ऑफ लेट्रोजॉल. लेट्रोजॉल की हाफ लाइफ क्या होती है? बड़ा ही फैक्चुअल क्वेश्चन है. नाउ लेट्रोजॉल इज एन एरोमेटेज इनहिबिटर, राइट? एरोमेटेज इनहिबिटर होता है. And what is the half life? It is used, सबसे पहले it is used for inhalation, induction of ovulation and for treatment of breast cancer, that is postmenopausal breast cancer. Half life is 40 hours. So the correct answer that we'll write here is 45 hours. Which of the following statement regarding use of 5-alpha reductase inhibitors in BPH are correct? Now BPH patients में 5-alpha reductase inhibitors like finasteride, they are used, right? Which statement is correct? So the answer is कौन सा correct है? Decrease in serum PSA, increase in serum PSA, decrease in cellular testosterone, decrease in cellular DHT. Now इसमें these 5-alpha reductase inhibitors, finasteride, another drug is dutasteride. They inhibit or block the conversion of testosterone to dihydrotestosterone. This is the main action. So they definitely reduce the cellular DHT levels. And then these medications will impact the growth of the prostate and resulting in reduction in the size of prostate also. So that way they'll improve the symptoms. And serum PSA, in order to compare with pre-finasteride PSA levels, serum PSA levels in a patient taking finasteride should be doubled. Okay. Now, sorry, serum PSA is reduced in approximately 50% patients receiving finasteride therapy. So here, decrease in serum PSA and decrease in serum DHT, cellular DHT are two options. If I were given a chance, I'll mark this because this is the first action of 5-alpha reductase inhibitors. Next, a 42-year-old chronic alcoholic presents to the emergency with altered sensation and seizures. He has not consumed alcohol for last 2 days. Okay, so investigation में serum ALT is 150, AST 180, GGT is 563. Now, what is the best drug in the first line management of this patient? Now, this is basically alcohol. The patient is suffering from alcohol withdrawal seizures, right? So, in this case, we would have used diazepam और chlordiazepoxide, but because it is a patient with liver disease, liver के markers क्यों दिए इन्होंने, है ना? लिवर डिजीज है तो हम यहाँ पे लोराजिपाम यूज करेंगे. तो ये आंसर जो है कई बच्चे इसको गलत मार्क कर सकते हैं, बट रिमेंबर दैट बिकॉज ऑफ लिवर डिजीज वी आर गिविंग लोराजिपाम इन दिस केस. नेक्स्ट, ACTH is the treatment of, ACTH is given in the treatment of juvenile myoclonic epilepsy, West syndrome, Dravet syndrome, Lennox-Gastaut syndrome. Now, in of all the options that are given here, जुवेनाइल मायो सब में बेसिकली इसमें सब में यूज़ होता है. ACTH वेस्ट सिंड्रोम जो होता है, ये वेस्ट सिंड्रोम होता है 2 to 12 मंथ्स एज में, और इसमें बेसिकली ट्रायड होता है. 3 चीज़ें होती हैं. क्या होते हैं? एक तो इन्फेंटाइल स्पैजम्स होते हैं, राइट? सो स्पैजम्स, देन EEG फाइंडिंग आर कैरेक्टरिस्टिक ऑफ हिप्स अरिथमिया, and then they have a developmental regression. So ACTH is the treatment in West syndrome patients. Next, a patient of psychosis is being treated with risperidone. He presents to emergency with upward fixed gaze. So what will be the treatment in this case? So upward fixed gaze मतलब कि इस patient में क्या हो गया? Now we know that risperidone is an atypical antipsychotic drug. Now ये एक तरीके से the patient is having dystonia, and dystonia में the drug of choice that we have to give is anticholinergics. So anticholinergics में हम यहाँ पे उसको देंगे intramuscular promethazine. Now promethazine हो गई या triaxiphenidil. These can be given to the patient. 30-year-old female presents to the OPD with hypomania. She has a past history, wants to conceive. So which drug is most teratogenic? Most teratogenic पूछ रहे हैं. Valproate, lithium, carbamazepine, olanzapine. Now out of this, see, lithium is safe, olanzapine is safe. Valproate and carbamazepine में valproate is more teratogenic. So the answer here is valproate, and it is the most teratogenic and should be avoided. Next, which of the following options correctly represent the increasing order of potency of inhalational anesthetic agents? Now remember one thing, that potency is inversely proportional to the minimum alveolar concentration. So more is the MSE of a particular agent, less will be the potency. So now methoxyfluorine, halothane, isoflurane, N2O और ये वाले दोनों ऑप्शंस तो गलत है क्योंकि N2O का सबसे ज़्यादा MSE होता है and so it is having the least potency. तो N2O has to be here. Now N2O से बाकी सबके ज़्यादा ही होंगे, so इसलिए ये वाला ऑप्शन सही है. methoxyfluorine का maximum potency, then halothane का, then isoflurane, then N2O. Remember, so just remember the MSE of N2O is the maximum, so it has got the least potency, so it has to come at the number 1 position. Now here you see the given diagram shows the steps in the formation of bacterial cell wall. Identify the site of action of beta-lactam antimicrobials. Now I know the diagram is not very clearly visible, so I really cannot do justice with this question. This is the site of drug A, this is B, this is C, and this is D. Now remember that beta-lactams, they basically inhibit the enzyme transpeptidase, right? They inhibit transpeptidase, and this inhibition of transpeptidase then results in inhibition of cross-linking of peptidoglycan moieties, So this is the action, and this action is here D. So answer here is this D. That is for the beta-lactam antimicrobials. A pregnant female with history of lepromatous leprosy presents to the OPD with type 2 lepra reaction. Management in this case is add corticosteroids. Don't stop MDT. Don't give thalidomide. Add corticosteroids with the treatment that is going on. Active metabolite of cyclophosphamide. Cyclophosphamide is an alkylating agent used in the treatment of various cancer. So cyclophosphamide is activated by the enzyme CYP2B 2,4-hydroxy cyclophosphamide. Okay. Now this 4-hydroxy-cyclophosphamide, this is the active metabolite. They are carried in the circulation to the tumor cells, where then there is another metabolite, aldophosphamide, and this also cleaves, generating phosphoramide, mustard, and acrolein. So they give rise to phosphoramide, mustard, and acrolein. Now phosphoramide mustard, it is responsible for the anti-tumor effects, and acrolein is responsible for the hemorrhagic cystitis, right? So these are the two side effects. So the answer here is 4-hydroxy-cyclophosphamide. Then this 4-hydroxy-cyclophosphamide further oxidized, and it forms 4-keto-cyclophosphamide and other inactive metabolites like carboxyphosphamide. Now these questions are something related to the immunosuppressants. Immune checkpoint inhibitor approved for treatment of advanced endometrial carcinoma is. Now out of all these agents, the immune checkpoint inhibitor which is approved for treatment of endometrial carcinoma is pembrolizumab. Now what are these immune checkpoint inhibitor? They bind to PD-1 and they stop the inhibitory signals. For the T cell. So it results in activation of T cells, right? And T cells then act against the tumor cells and kill the tumor. So it is used for a wide variety of cancer along with advanced endometrial cancer. The next is, which of the following is not an immune checkpoint inhibitor? So the options are cetuximab, pembrolizumab, atezolizumab, and nivolumab. Now these nivolumab, atezolizumab, pembrolizumab, they are checkpoint inhibitors. They are inhibitors of PD-1. While cetuximab is an inhibitor, monoclonal antibody against EGFR. EGFR के against monoclonal antibody है. And these checkpoint inhibitors, as we discussed, they reduce the signals, inhibitory signals for T cell, activate them, and so they restore the immunity. Significant side effects are seen with these checkpoint inhibitors, like they cause hepatitis, then colitis, pneumonia, and they also cause diabetes mellitus type 1. The drugs are nivolumab is there, atezolizumab, pembrolizumab is there, then ipilimumab, simplimumab, and avelumab, and durvalumab. All these drugs are also immune checkpoint inhibitors. The next question, which drug is not indicated in the treatment of sickle cell anemia? Bebtelovimab, N-glutamine, hydroxyurea, voxelotor. Now out of these drugs, bebtelovimab is not indicated. It is a monoclonal antibody against COVID-19. So it is not given in sickle cell anemia. What are the treatment options? For sickle cell anemia? So we have number 1, L-glutamine. L-glutamine is shown to have a good influence. Then omega-3 fatty acids. Then hydroxyurea is used. Hydroxyurea, it increases the hemoglobin F levels. It also reduces the frequency of painful crisis. Then we have crizanlizumab. This is an monoclonal antibody against P-selectin. So this reduces vaso-occlusive episodes by 50%. Then we have voxelotor. It also increases the hemoglobin SS in patients. So this is the treatment option. And last is we have allogenic bone marrow or stem cell transplantation. Okay? So out of all these options, this is not used. This is the drug used in COVID-19 patients.